Hello, it's a pleasure to be here. I'm going to discuss the follow-up of differentiated thyroid cancer. And I need to preface this discussion by noting I am going to very heavily reference current recommendations from the 2015 American Thyroid Association guidelines for the management of differentiated thyroid cancer. But these guidelines are about to be updated. So there will be new guidelines coming out in 2022. And I suspect that much of what I share with you today is about to shift. And I am going to share with you as we go along some of the places where I think new guidance may change what we're doing today. So what I'd like to do is to start by just walking through the various modalities we have available for surveillance for recurrent or persistent tumors in our differentiated thyroid cancer patients, and then to talk about how we follow those patients, either patients who get no surgery at all for low-risk tumors, or those who get some amount of thyroid surgery with or without radioactive iodine therapy. And then briefly we'll discuss at the end the other important piece in the follow-up of our thyroid cancer patients, which is determining the degree of TSH suppression, both post-operatively and across the ongoing follow-up. So to start with, in thinking of modalities that we can use to watch for the recurrence of thyroid cancers, thyroglobulin in many of our patients is a mainstay of this. Serum thyroglobulin is affected by mass of both benign and malignant thyroid tissue, and also by the degree of TSH stimulation. And important to remember that that can be stimulation from endogenous TSH, from recombinant human TSH that we give our patients. In pregnancy, it can be stimulation from HCG, which does stimulate the thyroidal TSH receptor. And finally, in our minority of patients who might also have Graves' disease, this can be stimulation from TSH receptor stimulating antibodies. Current guidelines recommend that for our patients who do undergo thyroid surgery, during the initial postoperative follow-up, we should check a serum thyroglobulin on thyroxine therapy about every 6 to 12 months, possibly more frequently in those patients who have high-risk tumors. But timing of our initial baseline assessment matters. Important to note that in patients who have thyroidectomy, just the surgical manipulation of the thyroid gland at the time of the operation can cause an increase in serum thyroglobulin levels, and that has a pretty long half-life. So those high thyroglobulins can persist for a number of weeks. And it's recommended really we should wait a minimum of 4 to maybe ideally 6 weeks postoperatively to get a first baseline thyroglobulin and be sure that it's a meaningful value. After radioactive iodine treatment, which has sort of a more prolonged duration of action, we should probably wait a good 3 months before really being convinced that we have a baseline thyroglobulin. If you measure sooner, just interpret those numbers with caution. Measuring thyroglobulin accurately is a challenge. This is illustrated by this study by Carol Spencer, who measured serum thyroglobulin in 68 different patients, none of whom had thyroglobulin antibodies, and measuring across 14 different assays, they found a big variation in thyroglobulin measurements that was pretty assay specific. And that's despite the fact that we have an international reference standard for thyroglobulin assays. They are calibrated to the same standard. That doesn't seem to help as much as we would like. So radioimmunometric assays may be less variable than immunometric assays, but it's those immunometric assays that are more widely available. And the key here is that we can't really use different thyroglobulin assays interchangeably in clinical care, that ideally we would use the same assay over time in the same patient so that we are sure that changes in thyroglobulin levels are truly meaningful. Now, the thyroglobulin is challenging enough to measure in patients who are thyroglobulin antibody negative, but in patients who are thyroglobulin antibody positive, it is even more challenging, maybe not really feasible to come up with reliable numbers. Again, radioimmunoassays may be less affected, but really all assays can provide spurious results in patients who are thyroglobulin antibody positive, and it's not necessarily clear that we can generally trust those serum thyroglobulin values in those patients. And instead, in those patients, what we can use is the thyroglobulin antibody titer itself. And again, a figure from Carol Spencer demonstrating that in those patients who were initially thyroglobulin antibody positive, that many of them will have a reduction in antibody titers. They often become antibody negative at about a median of 4 years after thyroidectomy. but that a 50% decline in the thyroglobulin antibody titers will predict a very low likelihood that there will be recurrent disease detected over follow-up, whereas a rise in thyroglobulin antibody titers of at least 50% is concerning and is associated with a higher risk of about 40% of persistent or recurrent disease. Now, the other modalities we can use for tumor surveillance are all imaging. So neck ultrasound is really the mainstay for this in all of our patients, at least in the initial postoperative setting. And it's recommended that all patients have initial neck ultrasound 6 to 12 months after surgery, and then periodically, and the frequency and the duration for which we need to do ultrasound monitoring is going to depend on our risk and our response to therapy over time. If you detect a node that looks suspicious on neck ultrasound, that should be biopsied if having a clear diagnosis of malignancy in that node would change clinical management. And really, if that lymph node is at least 8 millimeters in smallest dimension, smaller nodes, for the most part, we can just watch without biopsy. And what we're looking for on ultrasound is nodes that look concerning. So benign nodes tend to be sort of flat, oval-shaped. The short axis is typically 8 millimeters or less. In larger nodes, we may see an echogenic or a vascular hilus, but malignant lymph nodes look different. So they're often more rounded in shape. They may be cystic or partially cystic, or they may be solid with a texture similar to normal thyroid. If you see microcalcifications in a round-looking lymph node, that's pretty pathognomonic for the presence of metastatic papillary cancer. Radioactive iodine has been the other imaging modality that is relatively widely employed in follow-up of our thyroid cancer patients. So certainly any patient who's intermediate or high risk and is treated with radioactive iodine should get a post-treatment scan. And if there's uptake on that scan, there should be a follow-up scan 6 to 12 months later to ensure that areas that took up iodine at the time of the initial therapy have resolved. So this can be used over the longer term to follow up patients with higher intermediate risk. And in patients where elevated serum thyroglobulin, and typically the threshold used for that is 10, where you suspect there is recurrent or persistent tumor, do not have uptake on radioactive iodine whole body scanning, then we may turn to PET scanning, because typically once tumors de-differentiate enough to be no longer radioactive iodine, they become PET avid. And so for that subset of patients with advanced cancers, PET scanning is our mainstay for follow-up. We occasionally use other imaging modalities. So non-contrast chest CT is recommended when the thyroglobulin is elevated, or in the antibody-positive patients when there's a significant increase in those thyroglobulin antibody titers, with or without a negative radioactive iodine scan. It's really looking for lung metastases. And CT or MRI of the neck and upper chest is helpful if you suspect potential tumor invasion of the aerodigestive tract, or if you feel like neck ultrasound is not adequately visualizing neck nodes. And we occasionally, less frequently, consider MRI or CT of other structures in patients where we suspect metastatic disease and there are symptoms that might be attributable to those organ systems. So that's what we can do to surveil in our patients. So let's turn now to strategies for surveillance in different classes of patients. And the first group to think about here is a group who gets so-called active surveillance. So this is a relatively newer concept in much of the world. It's been done for a long time in Japan and is starting to be done in other centers. But this really gets at our concerns about thyroid cancer overdiagnosis and thyroid cancer overtreatment. These are US data, but these have been replicated in many other parts of the world. And what we've seen over past decades is a huge increase in the incidence of thyroid cancer, mostly papillary cancer, without a concomitant huge increase in thyroid cancer mortality. So that mortality may be increasing, but it has increased much more slowly. And this suggests that we are probably diagnosing and treating patients who don't really need diagnosis and treatment because they weren't going to go on to die of their thyroid cancers. And so one way to de-escalate therapy a bit is in patients with very low risk tumors to not opt for thyroidectomy at all, or even lobectomy, but just to watch. And this active surveillance is suggested as a potential strategy in the current ATA guidelines, but those guidelines really don't tell you how to do it. So they say you can consider this in patients, with microcarcinomas or patients who are at extremely high risk from comorbidities for having thyroid surgery. I think the new guideline is going to give us much more guidance about how to actually do this and how to select patients. But in the meantime, we do have studies that suggest that there are patients who are sort of optimal patients for this active surveillance strategy and others who may be less optimal. So patients in whom we might consider following thyroid cancers without ever sending the patient to surgery are those who are older, mostly because we know that tumor progression is more likely in younger patients, particularly those under the age of 40. Typically, we would recommend this only in patients where the tumor is low risk based on ultrasonography. So something that's a centimeter or less in size. Ideally, it would be a tumor that's somewhere in the middle of a thyroid lobe, not right at the edge where it's sort of poised for invasion through the capsule. We would not typically recommend this in patients where there's known evidence of spread based on imaging, so known or suspected lymph node metastases or extrathyroidal extension. And it's also important in considering this approach that patients be comfortable with being told that they have a thyroid cancer that we will monitor rather than treat, that they be willing to return for follow-up visits, because this does require active surveillance, not just sending patients away to get lost forever. And the mainstay of doing this is having high-quality ultrasound to monitor. So although the American Thyroid Association is not currently giving us guidance about how to do this, the Japanese Association of Endocrine Surgery does have some recent guidance, which I think is useful. So they suggest that once we've opted for this active surveillance strategy, that we need to do ultrasound with an experienced ultrasonographer every 6 months for the first 1 to 2 years after you initiate this protocol. And after that, once a year if no progression is detected. And there's no endpoint on this right now. So if you are opting for this, it's essentially at the moment once a year forever. The triggers to send patients to the operating room and to sort of stop this active surveillance protocol would be growth of a tumor to at least 13 millimeters in size, of appearance of new lymph node metastases, patients who just change their mind and want to change directions, or some other reason to have neck surgery like concomitant parathyroid disease. And important and helpful that serum thyroglobulin is not helpful in following these patients. They have all of them an intact thyroid. And so the protocols really use ultrasound only and not serum thyroglobulin for surveillance. This appears, at least in these carefully selected patients in the centers that are doing this to date, to be a reasonably effective strategy. This is a meta-analysis pulling data from 4 studies demonstrating that, again, in a fairly carefully selected patient pool, only about 5% of patients over a 5-year follow-up had enlargement of tumor by at least 3 millimeters, and even fewer, only 1.6% had lymph node metastasis over that 5-year follow-up. So turning our attention to patients who are actually going to have some degree of thyroid surgery, how do we follow up those patients? And here, those patients really fall into 3 groups. So most of the guidance we have currently applies to patients who've had a total thyroidectomy followed by radioactive iodine. So I'll walk through that next. And then we'll talk about patients who have less aggressive initial therapy. And this is a concept that really was first advocated by Mike Tuttle, and that has been incorporated into current ATA guidelines. But this concept that at the time of operation, we do some initial staging. We use AJCC staging to look at risk for mortality. We use ATA risk categories that are low, intermediate, or high to look at risk for recurrent or persistent tumor. But then we continue to restage at subsequent visits. So we're always going to be incorporating patients' response to therapy into decision-making and scaling up or down our intensity of surveillance in response to that information. Now, in patients who get total thyroidectomy and radioactive iodine treatment, we can use serum thyroglobulin as quite a sensitive marker, essentially for the likelihood of cure. So patients who have achieved an excellent response to therapy have no nodes on neck ultrasound or any other imaging, and have serum thyroglobulin that's essentially undetectable on TSH suppression, or a TSH-stimulated thyroglobulin that doesn't go above 1. And we know these are patients who are going to do very well. The risk for recurrence is 4% or less, the risk for death is essentially negligible. And so these are patients where we should not be doing very intensive, ongoing, lifelong surveillance. That incurs costs, and that incurs a lot of patient anxiety, actually. So an excellent response to therapy should lead us to scale way back on the intensity and the frequency of our follow-up, and also on the degree of TSH suppression. So in low and intermediate risk patients who achieve this excellent response to therapy, we can space out the interval between serum thyroglobulin measures to at least 12 to 24 months. We do not need to do ongoing imaging. They do not need ongoing ultrasonography unless the thyroglobulin starts to increase. And in the high-risk patients, we don't want to relax as much. So in those patients who start out initially at high risk, we do probably at least for several years want to continue to do ongoing surveillance with ultrasound and thyroglobulins at least every 6 to 12 months. Now, patients with a biochemical incomplete response are those where you still don't see anything on imaging, but the thyroglobulin is unequivocally elevated. So on TSH suppression, it's greater than 1. With stimulation, it rises to greater than 10. Or these are the patients who have the thyroglobulin antibodies, and those antibodies are rising. And outcomes in this group are going to be very mixed. So about a third of them probably are going to spontaneously evolve to no evidence of disease if we do nothing. And about another 20% of them essentially are going to be cured after some additional therapy. But there are about 20% of these patients who are going to go on to develop a structural disease. So these are patients where we need to continue fairly frequent surveillance with serum thyroglobulin every 6 to 12 months and continued neck ultrasound every 6 to 12 months, and then additional imaging as indicated, as we've talked about already. An indeterminate response is frustrating. These are patients where the thyroglobulin is elevated, but not quite high enough to meet those biochemical incomplete thresholds, or where imaging is not unequivocally negative. There's something a little bit funny looking, but it's not clearly associated with recurrent disease. Or these are the patients where the thyroglobulin antibodies are around and they're stable or declining. So most of these patients will do fine. Things will remain stable, or these funny thyroglobulin or imaging findings will ultimately resolve on their own. But again, 15 to 20% of these patients will ultimately have structural disease identified, and so we need to continue watching these patients. So continue serial imaging, certainly with ultrasonography, and if there's a funny result on one of the other imaging modalities, continue to follow with that modality as well, and continue the serum thyroglobulin at least every 6 to 12 months for several years. Structural incomplete response, these are patients where we know where the disease is. We can see it, we can measure it. It doesn't really matter at this point what the thyroglobulin level is. Most of these patients are going to continue to have persistent disease, even if we give them additional therapy. And these are the patients where we worry about mortality risk. So death rates as high as 11% if there's local disease in the neck, or as high as 50% if there are distant metastases. And these patients are the patients who may be candidates for additional treatment, depending on exactly where that tumor is and how extensive it is. So these patients certainly we're going to be following closely with serial imaging, following closely with serum thyroglobulin, and pursuing additional treatment. So that's not the majority of our patients anymore, though, because most of our patients under current protocols are low-risk patients who do not need total thyroidectomy with radioactive iodine. So many of our patients these days get total thyroidectomy or just get lobectomy, and the question is, how do we follow those patients over time? And some guidance has been proposed for those patients who have thyroidectomy without radioactive iodine, and I am anticipating that the upcoming revised ATA guidelines will codify this and give us definitive thyroglobulin thresholds to look for. Right now, what has been suggested is essentially a slightly higher threshold for considering the thyroglobulin levels to be positive. Stimulated values up to 2 might be okay in these patients when the thyroglobulin antibodies are negative. So, and biochemical incomplete response, non-stimulated values over 5 for thyroglobulin, or stimulated values over 10, or again, the increasing antibody titers might be biochemical incomplete response. But again, watch, because I think that the new guideline will incorporate this and will give us sort of final numbers. It's also been proposed that perhaps we could use thyroglobulin following lobectomy. This is a paper from Mike Tuttle and colleagues. It's 5 years old now. And they suggested this thyroglobulin threshold of 30, but really subsequent analyses have suggested that this just doesn't work very well in patients who still have a thyroid lobe in place. And so one of the things that the ATA task force is doing in writing its updated guidelines is it's commissioned a formal meta-analysis to determine whether serum thyroglobulin is useful at all in following post-lobectomy. I suspect the answer is going to be no, but we'll see what they come up with. So right now we have a lot of patients for whom we actually don't have official guidance on how to follow and how to define them in terms of their response to therapy, but that is coming soon. So I think that will help a lot of us in our clinical practice. And then finally, the other thing we're doing always as we're following these patients, following their initial treatment, is thinking about, do patients need levothyroxine dosing high enough for TH suppression or not, and what degree of suppression is appropriate. And the first group, again, to think about is those patients who are low risk who might be on an active surveillance protocol. There are no randomized clinical trials right now looking at effectiveness of TSH suppression in active surveillance patients. So we do not have, high level evidence. We do have a little bit of cohort data, though, including this study that suggests perhaps lower TSH is beneficial. This was an analysis of 126 patients who had papillary microcarcinomas who were getting active surveillance. And they found that those patients where the TSH was greater than 2.5 were at higher risk for tumor size increase than those patients with the lower TSH levels. So maybe new guidelines are going to suggest some degree of TSH suppression in at least some of these patients. But you have to bear in mind that many of these patients opt for active surveillance in part because they don't want to be on levothyroxine in the first place. So waiting to see what new guidelines show here. For our other patients, those who have had at least some surgery, we do have guidance suggesting that we can determine the initial TSH target based on the ATA risk category. So high-risk tumors should really have suppression of less than 0.1 as the initial TSH goal. Low-risk patients do not need TSH suppression. The current recommendations are to basically keep them in the lower half of the normal reference range, and it's possible that that's going to be even relaxed a little bit with the new guideline. And the group with intermediate risk has sort of an intermediate TSH target of 0.1 to 0.5. But we need to change that over time, and we need to modulate that in response to therapy. We know that patients with high-risk tumors do have a survival benefit. So they have less risk of tumor-specific mortality if they have TSH suppression. And so that remains a very important part of their care. And even if they have an excellent response to therapy, those lucky patients who really seem to be cured, in the high-risk patients, we would not completely relax that TSH goal, suggested to maintain some degree of suppression for at least 5 years, even with that excellent response. But TSH suppression does incur risk. There's increased morbidity and even more increased mortality in suppressed patients, particularly those who are older or who have risk factors for bone and cardiac toxicity. So current guidelines suggest a scheme like this, that most patients outside the high-risk patients who have had an excellent response to therapy should not have TSH suppression. We don't want to oversuppress people and cause risk we don't need to. Patients who are at higher risk should have their degree of TSH suppression carefully followed, and we should perhaps relax the degree of TSH suppression in patients with comorbidities, including osteoporosis and probably particularly atrial fibrillation. So I would conclude by noting that in the long-term follow-up of differentiated thyroid cancer, our surveillance tools are primarily thyroglobulin in the serum and ultrasound in the neck. And the degree of TSH suppression and also our intensity of surveillance over time does depend on dynamic risk stratification. And we are anticipating new rules for how we do that in the very near future. With that, I'll thank you for your attention.
Hello, my name is David Cooper, and I'm happy to be speaking to you about subclinical thyroid disease. This is a large topic and very difficult to cover in a short period of time, but I will do my very best. I don't have any disclosures. I'm going to divide this talk into two parts. Part A, or part one, will be on subclinical hypothyroidism. We'll define it, talk about the clinical significance, talk about limited data on treatment, and then recommendations. And then we'll do the same thing for subclinical hyperthyroidism. You'll see that there are very much fewer data on treatment of subclinical hyperthyroidism compared to subclinical hypothyroidism. So before we can talk about subclinical thyroid disease, we need to talk about what a normal TSH level is. And of course, you're familiar with data like this from a large epidemiologic study in the US called NHANES, of 13,000 normal healthy people, and you can see that there is a distribution which goes up to approximately 3.1 to 5 for normal people. But there's this tail to the right where there may be included in here some people with mild hypothyroidism and other abnormalities. And the 97.5% tile goes up to about 4.1 with a mean of 1.4. But you can see there are actually mild ethnic differences, so that Black individuals actually have a slightly lower TSH with a curve that's shifted over to the left. Now, there are actually many factors that can influence serum TSH. I've listed them here. Obesity is one, season of the year. I want to focus on age, though, as one of the main things that we need to worry about. And the data are based on this Haynes study, where you can see that the curve shifts over to the right as people get older. And so, in contrast to young people, where the 97.5% goes up to about 4 or 3.5, at age 80, normal could be even a TSH up to 7.5 due to this shift. The reasons for this shift are not known. Whether it's due to alterations in the pituitary sensitivity to the T4 or other factors is not known. This is just another study from another group in Australia looking at the mean serum TSH down here in about 900 healthy people in 1981. And you can see in the same people, when they were retested in 1994, the TSH levels had shifted slightly over to the right. That is, gone up a little bit. And here is the change in TSH based on the age of the person. And you can see that people who were over age 60 had the greatest increase in serum TSH over that period of time. So subclinical hypothyroidism is obviously defined as a situation where the T4 and T3 are normal, but the TSH is elevated. The vast majority of people with subclinical hypothyroidism have a TSH between 5 and 10. Many, but not all people, have anti-TPO antibodies, and some people might call this mild hypothyroidism. This is a very, very common scenario. Up to 3 to 15% of the population have this, but of course, the prevalence of this depends on the upper limit of the TSH reference range that is used. And if you use a level of 4 or 5 or 6 in a very elderly group of people, the prevalence of true subclinical hypothyroidism is going to be less. Now, the issues in terms of why this is important and why it's important maybe to diagnose this and treat it is because of 3 factors. One, there may be altered cardiovascular outcomes based on lipids and cardiac function that need to be addressed. 2, patients who have subclinical hypothyroidism may have symptoms of hypothyroidism, altered function, altered cognition or mood. And then finally, if a patient has this, is it possible they will progress to overt hypothyroidism, which is a much more serious problem? So diagnosing mild hypothyroidism is an advantage because maybe you could institute treatment sooner. I want to talk about the first reasons to take this condition seriously, that is cardiac issues. And this is all based on the fact that we know that hypothyroidism itself is associated with a whole host of abnormal outcomes in terms of cardiovascular disease. It's associated with an atherogenic lipid profile, hypercoagulable state, abnormal hemodynamics, and abnormal non-traditional risk factors like Lp(a), LDL particle size, et cetera, and impaired endothelial function. And the question is subclinical hypothyroidism also associated with these things? And I don't have time to review this. It turns out, though, that in some studies, it is associated with some of these adverse effects. And I'll just show you this one meta-analysis that was published last year looking at changes in lipids with treatment of thyroid dysfunction. And you can see on the left, overt hypothyroidism, where there's a lowering of total cholesterol, LDL cholesterol, and triglycerides with treatment. And the same thing occurs with subclinical hypothyroidism. That is an improvement in lipid status, although it's much milder when subclinically hypothyroid patients are treated with levothyroxine. Now, the main data on this is based on epidemiology, because there really are no intervention trials to document that treating subclinical hypothyroidism benefits people. And I just want to go over these 4 studies here. Again, I do not have time to discuss them in detail, but the bottom line is that as the serum TSH goes up, the risk of coronary events, mortality, and heart failure goes up also in patients with subclinical hypothyroidism. So in patients with TSH levels between 5 and 7, there's really no significant change. But as serum TSH gets to 7 to 9, in this study, there was a significant change. And when TSH is above 10, which seems to be the line in the sand, if you will, then there's statistically significant increases in the risk of these coronary events and heart failure, although not with stroke. So in a way, you can think about it as the TSH goes up, there's increasing risk, which may start in terms of coronary heart disease mortality at a TSH of 7, based on this study, and it continues to go up. Also, just interestingly, there's no effect of having anti-TPO antibodies on coronary disease as long as the TSH levels are normal. And I'll just remind you of data like this, though. These are patients over the age of 85 looking at mortality rates based on TSH. And you can see here that as the TSH goes up in people, the mortality actually goes down. And this has been shown in a number of studies. So this is just a graph that shows some studies have shown that the risk of cardiovascular disease and subclinical hypothyroidism may be elevated, but it's mostly in people, if it does occur, with the TSH being above 10, and particularly in younger individuals. In other studies, there doesn't seem to be an effect of age and no increased risk. And then, as I just showed you, there may be actually a decreased risk of mortality in several studies, for example, like the one I just showed you. Paradoxically, as the TSH goes up, people may actually live longer. Now let's move on to talk about hypothyroid symptoms and other issues like that in terms of cognitive function, et cetera. This is a study looking at symptoms, looking at a group of healthy individuals who are either euthyroid, subclinically hypothyroid, or hypothyroid, looking at the number of symptoms. And you can see here that there's really no difference among these groups, except people that are overtly hypothyroid may have more than 4 typical symptoms, but otherwise you cannot tell whether a person is normal or subclinically hypothyroid by symptoms. In this study, looking at walking speed, that is the usual walking speed or the most rapid walking speed in people in their 70s, looking at TSH levels down here on the x-axis and walking speed on the y-axis. As you can see here, as TSH goes up, people actually seem to be able to walk more quickly, again, demonstrating that there doesn't seem to be an effect of subclinical hypothyroidism on function. And then in terms of dementia and cognitive function, here we actually do see that there may be an increased risk for dementia in people under the age of 75 with subclinical hypothyroidism, but not in people over the age of 75. And then finally, let's look at progression to overt hypothyroidism. This is the idea that you start out being euthyroid, you then develop mild thyroid failure or subclinical hypothyroidism where your TSH is elevated, but T4 and T3 are normal. But then eventually you become overtly hypothyroid with the T4 and T3 going below normal. Now the question is this an inevitable thing or does it depend on age and other factors? So in this study, looking at the progression to overt hypothyroidism, having positive anti-TPO antibodies was a powerful predictor of development of overt hypothyroidism over years. And it also depended on whether the baseline TSH was 5 or 10. And you can see here that in antibody-negative people, most did not progress to overt hypothyroidism over a 20-year period. But if the TSH was higher or antibodies were higher, then there was a very high rate of progression. On the other hand, in this study of 107 patients with a median TSH of 8 followed for almost 3 years, almost 40% of these patients normalized their TSH without any intervention to a median of 3.5. And again, antibodies were important. About 2/3 of patients with antibody who were antibody negative normalized their thyroid function, but only 30% with positive antibodies. And again, you can see when the TSH was between 5 and 9.9, more than half the patients normalized TSH. But if TSH levels were higher at baseline, that would be less likely. And in this study from Israel, looking at baseline TSH levels greater than 10, about 27% normalized their TSH over a 5-year period. And when the TSH was between 5.5 and 10, 60% of the patients, when rechecked, had a normal serum TSH. So, in fact, this progression is not inevitable, and actually maybe up to half the patients without any treatment at all normalize their TSH. And this depends on antibody status and the baseline TSH. So the question is, when you have a patient like this, should you treat them or not treat them? And unfortunately, there have not been a lot of randomized trials. There have been 4 here that I've shown you, and most of them do not show much of an effect on symptoms or on mood or anything like that. I want to focus, and I put it in yellow, on the STOT study, since this is the largest study. This is a paper from the New England Journal of Medicine where they studied 737 patients who were over the age of 65. Double-blind, randomized, placebo-controlled trial. 368 got levothyroxine, 369 got placebo, and the 2 primary outcomes were a hypothyroid symptom score and a fatigue score on a validated thyroid quality of life questionnaire. And the mean serum TSH at baseline was 6.4. In the placebo group, it had not really changed much, and it was 3.6 in the treatment group. And there were no differences at 1 year in the symptom score or the tiredness score. And the conclusion was that it provided no benefit, levothyroxine, that is, in people with subclinical hypothyroidism. This is a meta-analysis published in 2018 that included the STOT study, which I have put in green here. They looked at thyroid-related symptoms and quality of life in the 4 randomized controlled trials that had been published up to that point. And again, you can see here no evidence of any improvement in symptoms or quality of life. Now, ever since the TRUST study was published, there have actually been 3 other studies that have been subgroup analyses of the TRUST population. In this study, published in JAMA in 2019, they specifically looked only at people over the age of 80. There was no difference. In this study, published in 2020, they looked at patients who had the highest baseline burden of symptoms to start with, no difference. And then this study just published a month or 2 ago, looking at patients who at baseline had some depressive symptoms, no difference between T4 and placebo. Now, I can't stop there, though. I want to just mention this study. This is not a randomized controlled trial, but it's potentially an important study. This is from the UK General Practitioners Database, where a large number of patients were followed with subclinical hypothyroidism. Again, this is not a randomized trial, but some patients received treatment and some patients did not receive treatment based on their doctor's best judgment. So here we have 3,000 patients between 40 and 70. In blue, these are ischemic heart disease events, no treatment. In red, treatment, and there was an improvement, that is a decreased risk of events in patients that were treated who were over, between 40 and 70. But in patients who were over the age of 70, treatment versus no treatment was not statistically significant, although it looks like treatment actually may have been harmful with more events. This was not statistically significant. So it's hard to make any specific recommendations based on the limited amount of data. I think most people would say in patients who have TSH levels between 4.5 and 7. You should measure antibodies because they may predict progression. Annual follow-up is reasonable, and consider treatment in patients with multiple symptoms, positive antibodies, progressively increasing TSH levels. Obviously, any woman that is planning a pregnancy, and goiter may also be a reason to treat because there is some limited evidence that goiters may decrease in size with treatment. And of course, here we have patients 65 and younger, or less than 65. However, in older people, there's really no good evidence that treating up to a TSH of about 7 is valuable. In patients with TSH levels between 7 and 9.9, consider treatment because, as I showed you, some studies suggest an increased risk starting at a TSH of 7. And again, consider treatment in an older person as well. And then finally, a TSH greater than 10 is sort of, most people would agree, a reasonable line in the sand, if you will, that should be treated regardless of age. Now let's move on to talk about subclinical hyperthyroidism. So the definition is just the opposite of hypothyroidism, so a normal T4 and T3, but a low TSH, typically less than 0.1. And people have divided this into grade 1 subclinical hyperthyroidism, where the TSH is just slightly low, between 0.1 and 0.4, or a TSH less than 0.1, which would be more severe, or grade 2. Some people might call this mild hyperthyroidism. And this is a much less common entity that you're going to find compared to subclinical hypothyroidism. The number one cause by far is US, that is iatrogenic thyroid hormone therapy, accounts for the vast majority of patients who have this. But of course, endogenous is also seen and typically is due to the usual things that cause hyperthyroidism, Graves' disease, autonomous nodules, and multinodular goiter. And often in patients who are in remission, if you will, after antithyroids or radioiodine, that the TSH remains low, even though the T4 and T3 levels are normal. Now, the reasons to consider diagnosing and treating this include cardiovascular outcomes like atrial fibrillation, heart failure, and overall mortality, increased risk of fracture in elderly and postmenopausal women, symptoms, dementia, and the risk of progression to overt hyperthyroidism. And I'll just go over each of these quite briefly. Looking at cardiovascular outcomes, this is a study looking at the risk of atrial fibrillation in patients with subclinical hyperthyroidism, followed for 11 years. Here we have normal people, subclinical hypothyroidism, overt hypothyroidism, subclinical hyperthyroidism here, where the risk of atrial fibrillation was about threefold. And it didn't matter whether the TSH was between 0.1 and 0.4 or less than 0.1. And in this study from Denmark, a large population-based study of 4,000 overtly hypothyroid people, 6,000 subclinically hyperthyroid people, and 540,000 euthyroid people, looking at cardiovascular events. Here you see with overt subclinical and then grade 1 and grade 2 subclinical, increases in all-cause mortality and increases in heart failure. And in this study, looking at combined individual patient meta-analysis of 50,000 participants, 2,000 of whom had subclinical hyperthyroidism, there was an increased risk of coronary heart disease and mortality in patients with subclinical hyperthyroidism. Now, as you know, hyperthyroidism can cause bone loss in elderly and postmenopausal women. So maybe it does that in, maybe subclinical hyperthyroidism does that as well. And this is a epidemiologic study from Denmark looking at osteoporotic fractures in women. Here we have patients with low and normal TSH, where low TSH is defined as a TSH less than 0.3, 18 to 50 years old, no difference. But in patients who were 50 to 75 years of age, there was an increase in fracture in patients with low TSH levels, and in patients over the age of 75, again, an increase in fracture risk in patients with a TSH less than 0.3. The study also found that there was a higher risk of osteoporotic fractures in men who were 50 to 75 years of age, and in men who were over the age of 75. And then let's just talk about symptoms and dementia. So this is just a small study of 23 patients who were administered a hyperthyroidism symptom rating scale and a health survey. And the patients with subclinical hyperthyroidism did have more symptoms than the euthyroid controls. And then we talked about dementia and subclinical hypothyroidism. There's also some evidence that dementia may be related to subclinical hyperthyroidism. This is a meta-analysis of 5 studies showing that. And then finally, let's talk about the risk of progression to overt hyperthyroidism. This is a similar diagram to what I showed you before for subclinical hypothyroidism. But again, the idea here is you start out normal, you develop an increased T4 and T3 that are still within normal limits, but the TSH is now low since they're higher than they used to be. And then finally, over years of time, T3 and T4 become high and the TSH is low, and this is overt hyperthyroidism. The question is, what is the risk of this happening? And it's actually quite unusual, maybe 1 to 4% of patients per year. And the chances of becoming overtly hyperthyroid is directly proportional to the baseline TSH. So in patients with TSH levels that are less than 0.1, it's very, very common for patients to progress. Whereas in patients with just slight lowering of their TSH, most patients remain normal for many, many years. And in this study of 2,000 patients with subclinical, or these are actually just people, this is a population-based study with subclinical hyperthyroidism. Actually, many of them became normal over time without any intervention, and normalization was more common in patients with a TSH that was just slightly below normal. So in fact, patients can revert back to being normal, and probably many of these patients have Graves' disease that go into spontaneous remission. It's less likely when patients have a toxic multinodular goiter or solitary hot nodule to become normal spontaneously. So as a general principle in subclinical hyperthyroidism, it's reasonable to observe patients whose TSH levels are not so low and who are younger, and in patients that are older and have lower TSHs to treat them. That's an easy way of thinking about it. And in this chart, this is based on guidelines from the American Thyroid Association. Basically, in patients that are over the age of 60 or 65, it's reasonable to treat those people with TSH levels that are less than 0.1 and consider treatment in patients who are older with TSH levels that are on the low side, below the lower limit of normal, but greater than 0.1. In younger people with TSH levels that are less than 0.1, probably treat them, but there's really no data to show that treating a young person who has a slightly low TSH is going to be of any benefit. I want to just mention the risk of cardiovascular events in patients who are being treated with levothyroxine for thyroid cancer, and the goal here is to cause the TSH to be low. And you can see here that in patients with differentiated thyroid cancer on suppression therapy, the risk of atrial fibrillation is much higher than it is in control patients. And in this study, looking at overall cardiovascular mortality, the risk of cardiovascular death in people with thyroid cancer is much higher than it is in normal controls. And again, this is based on cardiovascular mortality being caused by TSH suppression therapy. So here are just some points. Subclinical thyroid dysfunction is frequent. It may progress to overt disease, but it may revert back to normal. Race and age affect certain TSH levels and suggest thyroid dysfunction if you use rigid reference ranges, and that's why it's important to take the patient's age into consideration with TSH levels going up with aging. Most older people who have TSH levels between 5 and 10 are healthy. When I say older, people in their 70s and 80s. Subclinical hypothyroidism is linked to some important cardiovascular risk factors, especially in middle-aged patients and possibly older patients, and especially if the TSH is above 10. And the treatment of subclinical hypothyroidism has not been shown to be of clinical benefit, except possibly in patients age 40 to 70, where there may be a reduction in cardiovascular events. Overreplacement with thyroid hormone is the most common cause of subclinical hyperthyroidism. Postmenopausal women and older men may have an increased risk of fractures, especially if the TSH is less than 0.1. They also may have an increased risk of dementia, cardiovascular death, atrial fibrillation, and CHF. And treatment of subclinical hyperthyroidism in older people may be warranted, even when the TSH is between 0.1 and 0.4, and certainly it's warranted when the TSH is less than 0.1. And then finally, and importantly, overly aggressive TSH suppression should be avoided in older patients with differentiated thyroid cancer. I showed you they have actually a higher risk of cardiovascular death and atrial fibrillation. I'll stop right there. And again, thank you very much for your kind attention.
So it looks like we have a question. If the surgeon is not a high volume one, would you do ultrasound and thyroglobulin after 6 weeks or 3 months? So the first thing, of course, is always, if we can, to send our thyroid cancer patients to high volume surgeons that we know that outcomes are better when the surgeon does at least 25 operations per year. But I think if you trust your surgeon less, more monitoring probably is appropriate. And if you don't really have a sense of how much normal thyroid tissue is likely to be left behind by a surgeon you're not accustomed to working with, also more monitoring and earlier monitoring might make sense. So the thyroid system to follow up with sub-centimeter nodules is causing a lot of confusion. How important is it to depend on this in our surveillance? So, of course, there are multiple TIRAD systems out there. There is an ACR TIRADS in the US, there's a Korean TIRADS, so there are a bunch of TIRADS, a bunch of systems that are all sort of using points. And at least in the US version of TIRADS, which is the one I'm most familiar with, many of the guidelines recommend not following at all if nodules are sub-centimeter. I think most of us probably would recognize that if something is clearly a micropapillary carcinoma, and often we have a pretty good sense of which nodules those are, that some follow-up probably is appropriate. And I really don't like to biopsy sub-centimeter nodules, but if you do, you need to think about active surveillance protocols, I think, for those patients, and trying to minimize intervention for very low-risk tumors. And I do not see other questions in the chat. So if there are no other questions, I thank you for your attention. It's a pleasure to be with you today.